I'm so sorry. There we go. Go
That's
ahead.
all right. Okay. So I'm going to walk through a few slides that's just going to provide a baseline understanding of who this workforce is and why it's so important that we're talking about them today. And I'm going to abbreviate, Meg, I've heard you say direct care and services workforce. That is, the terminology changes depending on what audience you're talking to. I'm going to refer to this workforce as the direct care workforce, really in an attempt to just make that possible to say, since it's kind of a mouthful with the full title. So approximately 4.8 million workers are direct care and make up the direct care workforce. They work across a whole range of settings, including home and community-based settings, nursing homes, group homes, supporting older adults and people with disabilities. This is a predominantly female, a predominantly of color, and an immigrant workforce. Next slide. It is also the fastest growing occupational group in our country. As you can see here, over the next 10-ish years, we're going to add over 1 million direct care workers to our economy. And that's really being driven by our aging population and by the fact that folks are living longer and will likely need help as they age. Next slide. So this is the number that keeps me coming to work every day, because I think this really summarizes in a visual way the workforce challenge that we face in long-term care. So this is the number of direct care total job openings. So it's
Forgive me.
Sorry, that's all right. So it's inclusive of the new jobs, right? That's related to the growth of jobs in this sector, but it also speaks to the fact that we have really high rates of turnover among the direct care workforce. And that means that over the course of the next 10 years, that we're going to have 9.3 million job openings that we're going to need to fill in order to keep up with the demand for services. So that's a staggering figure, and I think it speaks to really a larger issue around job quality that I'm going to talk about going forward. So next slide. So the number one issue that we hear about when we're talking about direct care jobs is that they are low-wage occupations, right? And this certainly reflects that. I want to point out two things on this slide. One is that you see the blue line, that's that bottom line there. That's the home care workforce median wage. It's really important for two reasons. One is it's the lowest paid grouping within this occupational sector. It's the lowest paid occupational group. And it's also the fastest growing segment of this workforce, because more and more people are wanting to age at home and age in place, right? So it's really important, especially I think as you're thinking about how to create connection to support services, to really recognize that the entire workforce is really important, but the delivery mechanisms might actually be different for home care workers versus those that are working, say, in nursing homes and in institutionalized settings. Or other kinds of, congregate settings. Next slide. So what happens when you have a occupation that is characterized by low job quality? So certainly the low wages contribute to economic instability, and that's really reflected by a high percentage of this population living in or near poverty, and a high percentage relying on public assistance in order to make ends meet. We also see that this workforce has really disproportionate rates of occupational injury. It's a very dangerous occupation. They themselves experience a high rate of chronic health conditions and don't always have access to the healthcare support to manage those conditions well. And then just related to the workforce instability and that churn that I talked about before, its implications are that, not only do we have to fill a lot of positions, right, but it has implications in the day-to-day for workers who are experiencing on the ground vacancy rates where perhaps there's not enough workers to sufficiently staff a shift at a nursing home, and you're being asked to do more to care for more people. That has an impact on quality, and it has an impact certainly on the quality of services, quality of care. It certainly has an impact on the quality of the job, where you can imagine you might leave at the end of the shift feeling like you didn't do enough for enough people. I think the other piece just to point out here is that not only is it a high rate of turnover, it happens relatively soon in an individual's tenure as a direct care workforce, where a lot of people are leaving these occupations before a year is even up. And that has really significant impact on employers who have to allocate resources to recruiting, to training, to trying to just get enough people in the door so that they can respond to the need for services, as opposed to being able to invest those resources in supports for the existing staff and helping to create more positive work environment. Next slide. So just a couple of data points here for Maryland and DC. So two things to point out here. So the wage competitiveness number, you see it's $3 in Maryland and it's $5 in DC. That number is reflective of the median wage that we see reflected in occupations that are competitive with direct care. So they're relatively low barrier to entry occupations such as food services, retail, janitorial. And what that means is that if you're looking at trying to retain and recruit workers into this field, that those workers have options, right? And where they could be making more money in other fields. And this wage gap here in Maryland and DC is a pretty significant factor. The other thing I wanted to point out here is that in DC, we see a relatively high wage rate relative to the national statistics, but it doesn't translate necessarily into these workers being better off economically, where you see that public assistance figure being very high. And that really is indicative of the expense of living in Washington, D.C. and making ends meet in DC. So it's not always about, are they making more money? It's really, how does that money play out for them in the communities in which they live? I want to just draw your attention to two resources that are linked on this slide, and I'm sure we can share these resources with folks. But one is, they're both on the PHI website. One is the state index tool, which allows, which is actually, I think, a very cool interactive tool where you can look at different states and policies within states and compare them. So you can see what states are really innovative in terms of worker supports, and specifically direct care worker metrics. And it's just a cool tool to really measure yourself against other states, but then also find states that might be resources to you. And then the Workforce Data Center, I provided a lot of national data in this presentation, but all of that data is available for all states, broken out on our Workforce Data Center, along with a lot more data that I did not present today. So those two are good resources. And then on the last slide, one more slide there. One, I just wanted to flag this as an additional resource. The Atlanta Fed created what they call the CLIF tool, the Career Ladder Identifier and Financial Forecaster tool. And we've seen it, we've seen some states and municipalities put this to work as they're thinking about policy changes that could bring increased wages to this workforce, and really helping them think about then what kinds of changes in policy need to happen around their social safety net structure so that workers don't experience that increase in income that then results in them no longer being eligible for some of the social supports that they clearly rely on, and to create a more rational kind of approach to how to increase the overall economic well-being of this workforce. And I will leave it there.
Thank you very much, Amy. I think that was really incredibly informative. And so I wonder, are there some model initiatives that you think should be that could be pointed out in other states that you think help with are certainly stand as models, I guess, for supporting direct care and services workers that perhaps Maryland could consider modeling?
I think it's a great question. And I think as I thought about this, I mean, I think just the important thing to note is that, you know, there's no magic solution or no one solution, right, for how we solve this workforce crisis. And what we really have is a job quality crisis that has evolved over time, and certainly was highlighted and exacerbated by the pandemic. And so what I think what I think of when I think of good models, I think of, looking at where there's both the states that are really forward thinking about how to improve recruitment and retention, improve the overall quality of these jobs. And then also seeing that it also takes employers and it takes innovation kind of more at the local level, kind of in tandem with that. And so, a couple of things, I think, we've worked a lot with Michigan. They're a state that's been able to increase the overall wages and have been able to make a lot of progress, or really in the depths of this work right now, around rationalizing their training infrastructure. And those are things that really contribute to the overall job quality and will contribute to the overall stabilization of this workforce. And then I think it requires partnerships and strategies at the more local level to connect those workers to the infrastructure of supports that are available to them within their community. I think one provider to highlight is Knut Nelson, and I think this is sort of an important frame for this work, where they were very intent. They identified their home health provider in Minnesota. They identified that they had a recruitment and retention problem, right? They needed more workers, and how were they going to be able to attract workers? And they were very intentional about centering diversity, equity, inclusion into their organizational culture, and really rethinking how they supported staff and how they even operated all together and engaged, different voices, understanding what supports people needed, to really create a changed work environment and a place where people can thrive and where they want to stay and work. And it's really innovative work. And given the workforce demographics, I think that is just a really vital approach.
That is fascinating. I hadn't heard of them. Have you highlighted, is it Knut Nelson? Have you highlighted them in any of your work, or can we find them somewhere in a report that you did perhaps, or? So we've done some work. I can direct you on our website to some of the materials from that. And and certainly happy to facilitate any additional conversation around that. Sure. So in doing this report, and as I reached out to the workforce development initiatives, I realized, and because I hadn't really known a lot about them before I did the report, I realized that there seems to be that maybe they exist because job quality is poor. Is that a fair connection to make? That the fact that, so in Baltimore, there were at least 4 that I knew of that I think I reached out to. I interviewed at least 3. There, the Caroline Center, Bon Secours, Dwyer, and I know there are others. I think I also entered the Baltimore Alliance. I can't remember the whole, BAC is their acronym. Do they exist because job quality is so poor, and because some of them are faith-based or nonprofit organizations?
Sure. Yeah, I mean, I think there is a drive in need that comes from that. I'd be interested in kind of what other people's perspective are on that, but I would say I think that's a reasonable connection.
Yeah, so let's go to Maria. I'm going to now turn to Maria, who is COO of Dwyer Workforce Development. And so perhaps you could answer that. Thank you Casey, for putting the Baltimore Alliance in the chat. Sorry about that. My apologies. But Maria, if you could, speak to what you think about that, and then tell us, of course, about Dwyer.
I think that it really ties directly to Amy's data. I mean, the bottom line is that for a lot of direct care workers, even when they're working, they're still living in poverty, right? And they're still experiencing challenges that go far outside of their actual job. The job, if they're not having a great experience in the culture or the work, that exacerbates that. But I mean, I think the piece that Dwyer really focuses on is that concept, right? Is that how do we take people that are underserved, under-resourced in our community that want to work, that can work, and create not just a job as sort of an entry-level direct care service worker, but how do we sort of create a career ladder for them? And that's really our focus. And our belief is that people's current circumstances shouldn't determine their long-term plans. And so we, work with training providers to train CNAs and GNAs, and then to place them with vetted providers, with vetted employer providers, but we provide all the support that they need to do that. So it's not just about the training and getting to training and learning the training and getting clinically prepared. It's about the car that breaks down that they have no safety net for, or the childcare because your kid is sick and now you have to go get them, or the transportation issues, or the housing instability issues, or the food desert issues. And so for many of us, we have a sort of safety net that if any of us experience any of those challenges, that we would be able to draw on, and people who've lived in systemic poverty doesn't necessarily have that. And so our goal is to really meet people where they are from the very moment we engage with them or they express interest in going into CNA training, walk them through that process in every way that they might need. So every burial removal that they might have, from all the things I just talked about, childcare, transportation, housing instability, but a lot of it is coaching too, sort of that support system to say, you can do this, get them through training, and then provide them an opportunity to be employed in places that sort of make sense for them, right? Close to their homes, or access to public transportation if they need that, but continue to support them. I mean, this isn't brain surgery. All of y'all know this. I mean, I was in a nursing home worked in a nursing home for 8 years, and I certainly experienced it. But as an employer, you can only do so much. It's a fine line between how you can support your staff and walk that path with them. So we stay with people for a minimum of 2 years, and support them in those efforts in any way that they need to be successful. But the piece that's really key is that after they've been a CNA or GNA for 1 year, we will pay for them to upskill into any other healthcare career. So med tech, P tech, pharm tech, rehab, up to be an LPN or an RN or PA. Like, that's our goal, is to get people from making the $14 and whatever cents that Amy cited, to making 5 and 6 figures, depending on kind of what they decide to pursue, and really doing that in conjunction with employers. I mean, I think that we've seen more, particularly in senior care, openness to being more flexible, to figuring out how to meet the employees where they are, to understanding the circumstances that might be driving behaviors, and to invest in them in the collective. Before COVID, there was always another group coming behind them. So to be honest, there wasn't as much of a focus on how do we retain people effectively. There was because there's a lot of rules. It's a heavily regulated industry, right? So how do you provide support for your employees, be there for them, at the same time recognizing that you have compliance issues that you have to be focused on, as well as, and certainly most importantly, the care of the patient and the resident. So figuring that out and doing that in conjunction with both the provider, the trainer, and the person, you know, the scholar, we call them Dwyer scholars, is really the magic, sort of the sauce, right? It's not something that we all, I'm sure probably everyone on this call is like, oh, well, if we provided more wraparound services, people would be more successful. But there's no funder, right, for that generally, right? There's not a payer source that allows that to happen. And so part of our work is to make sure that we create that opportunity to connect people where they are to an employer that makes sense for them, to a long-term career path, so they aren't leaving being a CNA to go to, you know, Dunkin' Donuts and making $18 an hour to serve coffee, which is a lot less difficult than it is to be a CNA. So how do we create the vision for career and focus and long-term sustainability and independence for individuals? And that's really our goal.
Excellent. So what geographic area does Dwyer serve in Maryland?
Baltimore City, Baltimore County, the Eastern Shores, and Frederick is kind of where our work is. We've been focused mostly in this first year and a half on Baltimore City and Baltimore County. And we have very excitedly gotten additional funding through the EARN grant from the Department of Labor to expand our work onto Eastern Shore and into Frederick. So happy to, always looking for partners, both provider partners, but also really other nonprofits. One of the most successful kind of pipelines that we've created is working with nonprofits who serve, you know, underserved populations, faith communities that are serving people that might be interested in this work, and then connecting them with us and creating sort of this pipeline of support from a trusted referral source. Because, you know, mostly people say to us, what's the catch? You know, people who have been underserved are used to there being a catch. And the question is always, well, do I have to pay the money back if I don't like it? If I hate, you know, if I determine that I don't like working with old people like I thought I did, or, you know, any of those issues, we, you know, it's no catch. So we try to really partner with those people that the person already might connect with, might have a trust relationship with, to make sure that we are being able to support people on a continuum, because we know we can't do it all either.
So I see that actually Secretary Roque, Secretary of Aging Roque, put in the chat, she asked a question, which I think is a good one for you. How does this intersect or push the push for apprenticeships programs in Maryland? So do you intersect at all with the apprenticeship programs, and how so?
So to be honest, we haven't had a lot of luck in Maryland in terms of being able to intersect effectively with the apprenticeship model, but we are doing it in Texas, who has a very large focus on apprenticeships and a lot of investment financially, but a lot of structures from their workforce boards to support that kind of experience. And so we are piloting one in Houston right now, a CNA, because they don't have a GNA, because, you know, virtually no one else does in the world. The CNA apprenticeship model in Houston, where we will, we've committed to training and placing 500 CNA apprentices in the Houston area.
Wow.
So I would love to do more in Maryland. If anyone has a better suggestion on how we can access that. We haven't been very successful, to be honest, to date.
So what have been the barriers, would you say? Is it?
I think that the model is complicated for CNA because the training isn't very long, right? So you had to in Houston, they developed a model that includes the basic training for CNA, but to get to the hours you need for an apprenticeship model to work with for the Department of Labor, they have added sort of an opportunity for the scholar to either pursue entry level, so beginning exposure to either EKG or phlebotomy, to get to the total hours that you need for both classwork and on-site work.
Thank you. Thank you, Maria. So I'm going to move next to Debbie Rowe with Genesis Healthcare. And so I think, and this probably dovetails, I'm curious if you could tell us what your own internal workforce development is, describe it, and how, if you've worked with other external workforce development initiatives in the area.
Yeah, so thanks so much. And I just want to thank you very much for the opportunity to participate on the panel. So I just want to share that Genesis journey in terms of workforce initiatives and strategy actually has been over 25 years. So we initially started with a Genesis approved nurse aid training program in a center with a dedicated instructor, and it was approved by the Maryland Board of Nursing. So what we did is we took that model and we did it in a cluster approach. So we took our neighboring centers to make a full class in terms of nurse aid students so that they would strive toward that certification and the GNA. So that was the beginning of our journey. We wanted to have a uniform policy that was, or program rather, that was approved in that state. And we actually expanded it to this state. We are in 19 states. We have over 100 nurse aid training programs. We not only do a traditional program that is approved in the individual state. So every state is different, even though there's federal guidelines, every state is unique. That basically what we've done is that in terms of our nurse aid training, that we not only do traditional, the brick and mortar, but we've also entertained and used the option of a hybrid. So all the classroom is done in regards to on a third party that we use. It's an ACA approved program. It's called CNA Online, and it was actually the initial architect of a temporary nurse aid that was used during the pandemic. So basically, we have been using a hybrid model. The first one we piloted is in West Virginia. We've expanded that model to multiple states where it's allowed. And that is another option for a pipeline of those candidates that go in our nurse aid training. And then the third mode that we've done in terms of nurse aid training has actually been sponsorship in nurse aid training programs. So while we were working to get approval in some of the centers for training, we actually at the same time, we're also working with sponsorship in terms of the school. We have operated through those 25 years on an earn and learn model, which is actually the components of apprenticeship. And basically what it is, we evolved. So we took that best practice in terms of earn and learn. So they are getting, we attract from the communities that we serve, basically, and we also utilize our own employees, incumbent workers that may be in environmental, laundry, or actually, employee referrals has been a big base. And then basically what we do is we work with them all the way through and support them all the way to state certification and licensure. During that journey, when we first started out, the nursing center said, okay, well, can you do medication aid? So in Maryland, we could not do the site training right in person, through our own instructor. We used the community college, and that started our relationship with the community college. And we learned that we did better, not just for them to go externally and attend the community college, but we did it on site. So we've actually operated medication aid training. They do allow it on site in other states, and we have progressively done that stackable credential. The other part that as we continued our journey, we did a lot of partnerships. So you will see that the reference is the Baltimore Alliance for Careers in Healthcare. I'm a board member of that, but we actually work with the Baltimore Alliance in terms of the LPN apprentice. So we've been involved with them since 2020, and we have had graduates in terms of LPN apprentice. And then throughout the states, as I referenced, we've done 19 states. And Meg, I got to be honest, there's some really common denominators. We actually have a national dashboard in terms of our company-wide data. So I can share with you, in terms of graduation rates, where the state passing is. And I can share that there are some states, there is a direct relationship with passing your nurse aid training, and then also with passing your state exam. And I have to be honest, back in 2019 with our workforce metrics, we found that over 79% of our graduates in terms of the companies were passing the state exam. But right now that number has decreased, and that was a lot of suspension of state testing, that was done with the pandemic. But bottom line is, with the national vendors that have done a lot in terms of online or written, there is a competency in terms of computers. Do they have the ability to work on the computers and have that access for some of the state testing? So we've really kind of worked not only in terms of, again, we did CNA training, we did stackable credentials, we ventured into apprentice, so we've had over 100 apprentice that we've worked in with the community college. New Jersey, Bergen Community College had a multi-million-dollar, CNA apprentice grant that we partied to. But I think throughout this journey, it really did put a lot of emphasis in regards to the direct care provider. Career Pathways, Bach, they actually not only have a career pathway for acute care, but they also have it long-term care. So we can actually there's actually a career map that is available in terms of that. And we've seen, we've done over, 14,000, very conservative number, in terms of tracking, but we found over 2,500 have passed, in terms of been promoted in their career pathways. But I just want to be respectful all the time. But I do think that during our evolution, we've not only did the Med-Aid, we've done the LPN, we've worked in terms of RN. We have 500 clinical affiliations in the country. We do believe there's a strong relationship, in terms of our clinical affiliations with rotations. We also have university partners that offer discounted tuition for higher education. And we always avail ourselves in terms of branding Genesis. We actually have a who, what, where, how to be a nurse aide landing page. And all of that was done not only with the centers, asking them what worked, what were your specific recommendations, but the other part is we went to our National CNA Council and said, what do you think? Can you offer, does this appeal to you? And we built it, all those different collaterals based on their feedback. And, we really want to get to the heart of them to ask them. So I want to be respectful of time, very passionate about that. But, I really thank you. But there is an intersection between regulatory, legislature, and also, with the training. It's really a multi-focused approach, and you can't do it in isolation. And there are some definite things within other states that I have seen, since I've done this company-wide. They do an excellent program in Colorado. They just started it called JAWS. They actually promote long-term care favorably with their career technology, their CTE program. We've also seen the temporary nurse aid was an excellent program. It's sunset, but that was an excellent program. And there are other states that still use that model for 120 days for them to get certified. So I can go on a lot of states, but I want to be respectful of our other panelists. So thank you.
Thank you very much, Debbie. I do have a quick follow-up. So have you found in your, in developing this program, this incredible program over so many years, have you found and compared, is there a difference between your retention rates before and after the pandemic? I'm curious, but really if you found barriers to keeping people on either during the educational or training process, and then of course in jobs as well.
Yeah, I think the thing is that training is just one component, but our goal is certification and licensure. We have seen since the pandemic beginning, as I referenced before, those state passing, is that we have found that, definitely those that we have sponsored and hired, for nurse aid training, that they will pass successfully the class. Our company-wide data is over 84%, and that's over 22,000 people a year, consistently over the years. The thing is, it's the state passing. The bottom line is, think about it. There were a lot of national testing vendors. We saw a decrease. And then the other thing is a lot of states changed their state testing vendor. So we worked in Pennsylvania. There were a lot of delays. We actually worked in Maryland. There is a direct relationship with taking that state exam immediately versus waiting and them staying active. So those that pass the state exam, over 80% will stay active. The best model, frankly, is Maine. Their state examination clinically is probably one of the best. Some of the private state testing, I really think that's important. A lot of people don't see that data, but we worked giving objective data. We want to be part of the solution, so we gave objective data. During the pandemic, state testing delayed, cancellation because they didn't have evaluators, and that impacted people staying. You have 120 days. So, but like some of the things, Meg, that you were talking, so that was huge, very big. The other thing is there was a lot of lack. The other part you have to track is not only them passing the state exam, but you also have to see when are their credentials posted. So if the regulatory body has delays, and we've experienced that in Maryland, I'm looking forward to a lot of positive things to come, but the bottom line is if they don't get their credential posted, like, if there's delays, like we noticed that based on our data, delays in some of the states, If they don't post it, that impacts them in terms of getting their raise. It impacts them getting the recognition of their credential as a CNA or an LNA. And that is really crucial. So here they worked, they passed their state exam, they passed that nurse aid training program, but because there's a delay in being posted by the state regulator, it impacts them, and I really believe that is really crucial to look at that in each state. And we work with them. That's why we work with our state associate. We don't work in isolation, but we give specific examples so that those that can impact, can help and really identify that. Because frankly, we're really trying to advocate for that direct care provider, and help them in that journey to be successful. So that's really, important that we wanted to, and that's why we'll sit there in terms of long-term care, and I will go on the Hill, and I know in Maryland, you will hear me talk about it, the GNA, CNA, in 19 states we operate. Maryland requires that 2-tier in long-term care. In 18 states that we operate, they do not. And that is a definite opportunity, I think, in Maryland to really go ahead and enhance the caregivers in our state.
Thank you. Thank you very much, Debbie. I want to get to, in interest of time, I want to go to Cindy Frakes, who is the with the National Institute of CNA Excellence. Cindy, if you could tell us not only about NICE, but also a little bit about yourself, because I think that's very relevant here too.
Good morning, and thanks for giving me an opportunity to talk about NICE a little bit. NICE, the National Institute for CNA Excellence, was born as a dream child of the National Association of Healthcare Assistants. The NAHCA, the National Healthcare Assistants Association, has long seen and heard from nursing assistants where training is not adequate to prepare people to actually enter the job market successfully and to stay in that job successfully. And I'm going to add safely. Recently, NAHCA conducted a survey of a few more than 3,000. I'm not the best person to speak to this, but a few more than 3,000 certified nursing assistants. And those nursing assistants commented on where they needed increased training. And I found the results of that very interesting, because one of the topics that they want more training on is falls, which is a leading quality indicator problem for long-term care. And CNAs want to know not about falls in terms of what causes them. I think CNAs want to know, in real life scenarios, how do we prevent falls? What do we do about falls? How do we understand why the person is falling? And then get information out there to the employers or the physicians and nurses that are planning care for those people on what they know about why those falls occur. So I'm really excited to see NICE develop some training specifically around this for nurse aides. NICE's mission and purpose is to establish, and we have pieces of this done. Meg referred to us earlier as a startup, and that is true. We are still in a startup phase. And we have pieces of basic training established so that we could support employers or individuals or states in certifying nursing assistants, and using what we want to ensure is a best-in-class nurse aid training that is consistent across 50 states, across all care settings, so that the individual is adequately prepared and they've had the opportunity to learn from nationally recognized experts, something that nurse aid training today may not include. So, for instance, people from the Society for Post-Acute Medicine, AMDA, I still refer to them as, have created some of the content that we use to train. And we want that to be true across all things, including as we work on falls, that's going to include nationally recognized experts. NICE is also purposed with the development and the availability to employers best practice information for growing and retaining those nursing assistants, help those individuals that are employing CNAs today to give them career lattices and opportunities for career growth, again, with best-in-class training opportunities in things like leadership for the nursing assistant. My own background is I am a retired nursing home administrator and an executive from a Midwest long-term care chain that included assisted living and home and community-based services. I hear everything that everyone is saying today with those ears of a nursing home administrator that dealt with staffing and retention every day. I was fortunate to work in a state where we were compensated for retention through incentive programs. And I'm thankful to have had that opportunity to work with reimbursement systems in that way, rather than just the traditional reimbursement system manners, and to work with people who were cognizant of the impact of retention, not just recruitment and turnover, but what really leads to people staying on the job. And I will tell you that as a nursing home administrator, one of the most interesting, proud moments, I will tell you that's a bit of I smile because you're going to wonder why I would be proud about such things. But when I realized that we had about a third of our nursing assistants reaching an age where they could not physically do the job anymore. They had been on the job with us for so many years that we were challenged to come up with how are we going to utilize and retain these individuals and at the same time afford to replace them, because physically they were past the ability to do the job. And that was, like I said, a very proud, very challenging moment. I will tell you, I left direct care administration before I solved that problem. So I left that to the next generation to tackle.
Thank you, Cindy. So how do you think, I guess with regard to NICE, what are some of the other things about NICE that you think are useful in terms of supporting direct care workers in staying on the job, or at least staying, and also in training? Because I know that you have, it's an LMS online system, correct? The entire thing.
Correct.
Of course, right?
Training, the concept, which was, I think, very novel when the NACA leadership first conceived NICE. Online training didn't really exist. However, COVID-19 helped change that and open up that door. But the reason why online self-paced training is an advantage to improving the numbers of people that are in the profession is because of the very statistics that we saw from PHI about who those caregivers are that are entering the workforce. And they have difficulties and barriers to getting to brick and mortar classrooms Tuesdays and Thursdays from 6 to 7 or 6 to 9 p.m. or 8 to noon on Mondays, Wednesdays, and Fridays, because they are working mothers with childcare needs. They have transportation needs. They're often too far away from that brick and mortar institution. And so online self-paced better fits that working mother model of a person entering the profession that may not have the transportation or economic means to get to class. It also opens up the opportunity for career advancement and career growth by offering coursework in things that could lead to better pay, better job satisfaction, better resident care. For instance, restorative nursing techniques. If I were a CNA and I wanted to just go out and take this course, you can take the NICE course for restorative nursing and learn how to provide that level of service on your own time, not, again, going to that brick and mortar structured class that I'm already working probably more than one shift a day, at least 5 days a week, and then providing care. Many CNAs, by the way, are also family caregivers. So I leave my nurse aide job at the home health organization or skilled nursing facility or assisted living, and I go home and I take care of an aging parent or a dependent sibling. And those barriers create obstacles to CNAs growing in their careers, and also realizing that they have opportunities then to maybe get better paying jobs. And it's not that they don't want to do that, it's that they can't. Somebody's got to knock the walls down. And we want NICE to be an opportunity to knock those walls down. So my vision is that today, and we've adopted the language of the National Association of Healthcare Assistants for building a care force. And so I see our care force members as having completed certification class that is enriched with content that is needed to take care of today's dependent adult or dependent individual that's not in basic skills training. It also is an opportunity to go out and get these specialist training certifications like restorative aid, social services, activities, universal worker concepts for people that want to work in those settings where universal workers are employed, or many other specialties, just specialties. So once I complete this course, I can take this into my existing employer or new employer and say, look, I have initiative to grow in my profession and be recognized with money, with opportunity that they may not have today, and feel like they're stuck in a place that they can't move out of. The third level of our care force person would be a care force master. And that care force master is a person who's graduated from a preceptor program. They're knowledgeable about funding in long-term care so that they realize why decisions are being made and how to help impact those decisions from that direct care perspective, which is very key to the success of the organization, not just with resident care. Obviously, those people are the most valuable eyes and ears that are in that workforce to help make sure that people are kept in good environments. Kept, that was a terrible word, forgive me, but that they live, their opportunity to live in a good environment. But it is also an opportunity to help them stay well as much as can be if that CNA has the observation and reporting skills and communication skills. So a master is going to have completed coursework in things like communication, understanding the roles and the responsibilities of other members of the healthcare team. And then for home health, a little bit different, more customized to home health. If we think of the skills that are needed for the CNA in the congregate living setting, take those times 10 for home health. That individual is probably on site, one-on-one with a person, no support, no equipment, no call light. No, they have to work within the parameters of the home health aide's scope of practice, but still make decisions in the best interest of the person. And one of the key things that I have heard many people talk about is understanding their relationship with the resident and the family. That while they are very close to the individual, that personal closeness requires a high level of integrity on the part of the CNA that needs to be addressed in training. And those are the things that we're working on at NICE, developing that. And by the way, we're developing that with nurses and physicians, but also with nursing assistants.
Thank you very much, Cindy. So we've got about 8 minutes left, and I would like to entertain some questions, and I'd like to start. So if anyone has more questions, they want to put them in the chat, please do. I'd like to bring up a comment and have people respond, or someone respond if you'd like to, that David Rodwin, the vice chair of the collaborative, posted, which was about the issue with home care, with apprenticeships in direct care jobs in home care, because after the apprenticeship is done, the job still pays very little. So therefore, the apprenticeships may be unlikely to serve as a leg up for a higher earning job. Does anybody want to address that?
I think as I was trying to respond in the chat, I do think the apprenticeship model is designed around a certain framework of a job, right? It has a certain characteristics that include that include certain wage levels and certain growth potential. I mean, it's really designed to get people into occupations with a real growth capacity in them. And that's frankly not direct care jobs right now, systemically. And I think we've looked at the apprenticeship model and tried to advocate for really using it as a way of encouraging changes to direct care occupations and helping to really create that career ladder, really create a better model that, you know, could be appropriate for, or could align with the intention of apprenticeships. And that the imperative is really there to do that, right? Because of the growth figures that I was talking about at the beginning of this session. Like, we have to do something, right? And then like, and the federal government is investing a lot of money in the apprenticeship model. And to leave this workforce out of that and out of some innovative thinking about how direct care jobs can fit into that, I think is a huge mistake. And so we've really tried to push some different thinking on that.
And I think that's why we're trying to, at Dwyer, really trying to create the sort of, I'm going to call it pseudo apprenticeship, right? So they're being trained, they work in a facility for a year. They're working with provider partners that have agreed to do the mentoring piece that's required of the, you know, in an apprenticeship model. We share data every 2 weeks around where people stand. Their HR people call us to let us know, the case managers, if there's challenges that they're seeing on their end. So we're really working hand in hand to make sure the person is successful while removing all those barriers, but we're also guaranteeing them a payer source for their next stackable credentials. That is all about them and not their employer. We are always very clear. We are about investing in you. So if you want to stay at employer A after you do this, more power to you. If you want to move to employer B after that, it's your choice, as opposed to, not that it's not great for employers to invest in their employees, but you know, there's a commitment required back for the time of the money that's invested by the employer. And so that's part of the uniqueness of Dwyer, is that we're really about the person and being able to say, you know, you can be a CNA, a GNA, and you can do these other things, and we're going to pay for it. So you're bringing your investment of time, energy, and commitment to the work, but we're the payer source, and it's guaranteed. It's not if we like you. It's not if you're doing well. It's really around how do you kind of do that in a way that works for you on your time frame, in you know, over whether it's online, in person, a combination of all of those things, how you kind of go forward. Because, you know, I'm sure I'm guilty of having said it when I was in skilled nursing, that you can go from being a GNA to being a nurse. Well, unless you can pay for it, that's, you know, that's sort of a, you know, saying like I could be an Olympic athlete too, but there's a lot of work I have to do to make that happen, right? That is not just about my intent. And so part of what we're trying to do is really create this market that says, this is a career that starts here, and there is a clear pathway forward that is fundable for you if that's your desire as you go forward. And I think that that's kind of the goal of an apprenticeship program. So we're just creating that structure that's highly focused on the individual, and certainly in partnership with the employers and others as well. But I think that's critical, because I don't think people can move when your choice is to show up and be a GNA and do that incredibly difficult work, or you can go, you know, do something else in fast food or in catering, which has much more flexible hours and, you know, other things for $4 more an hour. And your focus at that level is often about paying the bills. It's not all the other benefits you're offering. It's not all about the healthcare and the 401, you know, 403B and the 401k, which we would like that to be, but that's a growth place, right? When people sort of change their mentality in terms of paying for their everyday bills, right? These are a lot of the direct care workforces. Amy, you pointed out, they're still trying to survive. They're the working poor in a lot of cases, right? They're particularly for women that have children, you know, that are by themselves and trying to hold all that together. You know, when you have a shift that must start at 3 or must start at, you know, 7 a.m. or must start at, you know, 7, you know, in the afternoon for, you know, or overnight at 11 p.m. Like knowing that you have a safe place to live, you have food on your table, you have someone to take care of your children, allows you to be a better employee, allows you to see a future for yourself that you don't have the luxury of doing when every day is a fight to kind of get to work just because that's, you know, that's your life and the experience that you're having. And being able to move people from that and help them get to those places is really, we're hoping, and the numbers are showing, we're showing, you know, 20 to 40% better retention rates of CNAs that are Dwyer scholars, GNAs that are Dwyer scholars in the senior care facilities than their comparison non-Dwyer CNA GNAs. And so we know it works. And I think we're hoping that we're not the only one doing this model. This is not our goal to be the only people doing this. We're just trying to highlight that it can work, you know, and how we can do it is a win for the employer, for government funders, for private funders to sort of invest in this workforce that will be more loyal to you, as you pointed out, Cindy, of having people sort of stay with you for the long haul when they're able to live a life that gives them some sense of independence and stability and is respectful, and of themselves and of their family units.
Thank you, Maria. I appreciate that. Someone just put in the chat, all these programs don't negate poor hourly raise. And I think that's really very important, probably to end on. I think although it's a negative note, but it's really, really very important to remember this. In our report, the Baltimore report that I mentioned at the outset, we did compare some of the wages to we looked at the MIT living wage calculator, and although wages have gone up since the pandemic, there are many CNAs, the wages that they reported, and of course those reported by the Department of Labor, were below or just hovering right around living wages. And it, as Maria pointed out, people are still, we're not going to be able to keep retaining folks in these direct care jobs until we're able to pay them more than a living wage. So thank you very much. And I will share the slides. I will send recordings and I'll send a recording link to folks. Thank you so much, everyone. We really appreciate you joining. This was really very interesting and informative. Take care, everyone.
Bye-bye.